I am Dr. Nathan Sadik, and this is a lecture on transitional bonding. It's also going to be referred to as transitional reconstruction. This is my second time recording it. The first time I recorded it, this is actually the third time recording this. I gave this lecture at the Academy of General Dentistry meeting in Arizona earlier this year, and the recording didn't work, and the audio wasn't all that good. So I re-recorded it the other day, and it was right before I was going to a CE course early in the morning as I was printing, 3D printing something in my office. And I was just kind of trying it out to make sure I could do it. I decided to do the whole lecture, and I spoke way too fast and stumbled over my words. And as I was watching it, I realized it's not my best work. So we're going to try it again. This is my lecture on transitional bonding. It could also be referred to as transitional reconstruction. This is a vacation that we just went on a little while ago. This is St. Vincent down in the Caribbean, and this is Sandals, St. Vincent, and beautiful diving at this place, beautiful resort. This is one of the reasons I do dentistry and do the things I do, so I can travel places and have a good life. And I want you all to do this. Travel, have fun. So let's see, where's my next slide? How do I get to my next slide? All right, nothing's working. All right, well, let's stop this. Oh, there it is. There we go. Let me move back. So, all right, we'll start here. Hi, my name is Dr. Nathan Sadik, and I am a general dentist. I practice in Gilbert, Arizona. And this is a lecture I did earlier this year with the Arizona Academy of General Dentistry at their meeting. The recording at the meeting didn't work out very well, and the audio was really bad. So actually, the other day I re-recorded this. I went to my office and I was 3D printing something in the morning before a CE course, and I recorded this just to try it out to see if my recording stuff worked. And I ended up doing the whole thing. And I was just watching it to upload it to Reddit and or YouTube for some Reddit people that asked me they'd like to see the lecture. And I realized I was speaking way too fast and just trying to get through this as fast as I could, because as I watched my clock, the time for me to drive to the CE event kept getting faster and faster. I'm very red today. I spent the entire day on the river in Arizona, paddleboarding. Very fun, but I did get a little crispy today. It's 117 out this weekend. So I got a little burnt. So if I look red, I am. Um, but this is transitional bonding, or transitional reconstruction is another name for this. Something I do a lot in my practice, and I think it's a great tool. And it was really eye-opening when I figured out how to do this, and how it could help my patients when I take on more complex cases, especially multidisciplinary cases. This picture is of St. Vincent. It's down in the Caribbean, right, kind of by Barbados and Venezuela. And this is Sandals, St. Vincent. Beautiful Sandals resort. I love Sandals. I can scuba dive there. And the scuba diving in St. Vincent is absolutely amazing. So make sure you take vacations and try out Sandals, St. Vincent. Beautiful island, wonderful food, wonderful people, great diving. As in every obligatory lecture you give, you kind of give your journey into dentistry. This is me back in high school. That's my brother Danny, and he was the straight edge one. I was the rebel punk runaway. Um, I was actually a high school dropout, and went back to high school, got married in high school, and then after high school, started having children very quickly a year after that, and I was going to UVCC in Utah Valley. It's now, it then went to UVSC. Now it's called UVU, kind of infamous right now, unfortunately. But I studied journalism there. Really enjoyed my time there, but I had another kid and wasn't making ends meet. And so I joined the Navy as a Navy medic or corpsman. And in the Navy, I became a medic, EMT also. I worked in the intensive care unit and the cardiac care unit, surgical wards, and in the emergency room, and really enjoyed medicine. Really enjoyed medicine, was going to go back to medical school, was going to go uh, become a doctor, become an ER doctor or surgeon. And um, the Navy was downsizing at the time, and so I didn't get accepted for any of the programs that I wanted, and I was on food stamps the entire time, and I never went anywhere. I never went on a ship. I never got to be with the Marines. I sat in a naval hospital for 5 years. Did very well, but couldn't get a raise. And so I told them, listen, I got to leave. I'm going to go back to school myself since you guys won't send me. So I got out and went back to Utah and went to northern Utah to Utah State University. And that's where I started working in the hydroponics lab. I've always been interested in biology and plants and research. And so I got a job working in the crop physiology laboratory, and I began to study science and try to figure out what I was going to do. I joined the pre-med program, pre-dent program, and I also got a job working for the guy that ran, Bruce Bugby, that ran the crop physiology lab, Apogee Instruments, at his company that designed light and temperature sensors. And I really enjoyed that. I was going to go back to engineering school. They were going to pay me to go to engineering school and come back and work for that company and then get my master's and PhD. And at the same time, I was still applying to medical schools and dental schools and thinking I might go that way. And I was also looking at biochemistry. At this time, I had 3 children, and dentistry came through first. And so we decided to go to dental school. And I went out to the Medical College of Virginia, Virginia Commonwealth University. My 4th child was born my freshman year there, and had a great time in dental school, made some lifelong friends, really fell in love with dentistry. I also knew that I wanted to own my own business. This is one thing that kind of drove me the whole time. I loved medicine, but I didn't want to work in a hospital and be under someone else's thumb. I wanted to own my own business. My father was an orthodontist, um, and so I knew I wanted to be a business owner, and that's what dentistry gave me. So it seemed to fit every bill. Getting out of school, I moved to Arizona, and with 4 kids, and got a job working with the local dentist for a little while. And then 2006 and 7 and 8, the economy was crashing. And so he didn't have enough work for me. And I ended up going and working at a amalgam mill, basically one of these corporate jobs, Western Dental. Absolutely hated it. It was soul sucking. And I thought, what did I do deciding to do dentistry? And so very quickly, I started to look at a way to get out on my own. I tried to build a practice, 2 practices, and right as I was signing the paper for the second location, the office right next to my house, Stone Ridge Dental, came up for sale. I bought that in 2008 and scrapped the other plans. Thank God I did, because the economy really crashed after that. But I've been at Stone Ridge Dental ever since. That's my main practice. It's a 5 operatory practice where I do a lot of bread and butter dentistry, CEREC, same day dentistry, but I also do a lot of complex full mouth reconstructions and multidisciplinary care, which what I really like. That's kind of where my sweet spot is. So, all right, enough about me. Let's move on. My disclaimer: I am a member of Spirit Education. I'm also a visiting faculty now. I've completed the core curriculum, and I go up and I help teach a lot of the stuff that I'm talking about. Really love Spirit Education. They're in Scottsdale, also over in, I think, Charlotte, North Kakalaki. I've not heard of them. Fantastic education experiences there. And I'll talk about some of the other education I've done over the years too. So the objective of this lecture, we're going to identify wear cases that can benefit from transitional bonding. Where can we use this concept? We're going to talk a little bit about basic smile design principles. That's a very big subject that takes a while to be able to understand everything. So you really need, this isn't going to cover everything. It's going to give you an idea of what I do in my practice for smile design principles. This is what I think Spear does very well, is smile design. Stephen Phelan also does this very well. We're going to talk about wax ups, analog and digital wax ups, and when we do them and how we do them. And then we're going to spend a lot of time talking about actually how to do the transitional bonding. I think conceptually, this is easy. The smile design principles are kind of involved, and I mean, they're kind of second nature for, at some point for me, but I had to learn them. And I remember learning them was difficult, took time. But I really want to get into how you actually do these in someone's mouth, because that's where the rubber meets the road. No matter how much we do, eventually we got to get our fingers wet, right? So start with a basic question. What is transitional bonding, or what is a transitional reconstruction? Put simply, in wear cases, it is simply making the teeth to proper shape and size prior or during multidisciplinary cases. So these are cases that come in that things have shifted. Maybe there's skeletal issues. Maybe there are crowding or spacing, and things have worn. They've broken or worn. So the tooth isn't whole anymore. And we need a team to help us work on these: an orthodontist, an oral surgeon, periodontist, and then you as the restorative dentist. Everybody's working together in these complex cases, and things can get lost, right? Um, so transitional bonding is very useful to help everybody on the team see what the goal is to make it easier. It's also used as trial therapy to stabilize occlusion and try out aesthetics in full mouth cases. When you cut the teeth, they're gone. And sometimes rather than making provisionals and working it out in the provisionals, we can work this out in a transitional bonding case. And basically something that is technically reversible, and we haven't cut teeth, we can say, does my plan work aesthetically and functionally for you prior to me turning this into ceramics, right? And the real big time that I love using transitional bonding or transitional reconstruction is phasing and sequencing complex worn dentition cases. What I mean by this: when people come in and they have worn dentition, perhaps they've lost vertical dimension, teeth have shifted. The reason they're wearing their cases generally is skeletal problems that have caused them to grind their teeth, maybe even TMJ issues. And when we want to do, um, reconstruction, oral surgery, periodontics, orthodontics, do all of these things to get a good case and that's going to last and look really good, it costs a lot of money. And not everybody that walks into my practice has 60 to $80,000 that they can drop all at once. So if we transitionally bond and reconstruct these cases, we can actually phase these over time and sequence them and make them affordable. And it also gets you to do more dentistry, because if someone says no to your dentistry and leaves, they're in the bad case and you haven't gotten to help them or do anything, you're not making money. So if we can make this more affordable and easier to phase and sequence over time, you now have a piggy bank of really good dentistry coming into your practice all the time. So I use it a lot in phasing and sequencing. So this is where we most people recommend it. After hearing this, they said, why are you calling it transitional bonding? Why don't you call it transitional reconstruction? Because that's what this is. So I should probably change the title of this, but I've always called it transitional bonding. All right, so let's look at a case here. This is, if this person walked into your practice, first off, how would you diagnose this case? What are the problems that you want to fix in this case? How do you develop the problem list? And then once you develop this problem list, you can start talking about where should the teeth be in the face, and how should the teeth be formed, and what procedures are available to fix this patient's smile, bite. And what you'll find is many times this is multidisciplinary. And this is a patient that needs some orthodontics, possibly some oral surgery, possibly some periodontal work, and it needs my restorative work. So if I send this patient to the orthodontist, what am I going to get back? Right? What am I going to get back? There's times when I was younger and I would send these cases to the orthodontist and I would say, "Hey, leave me some room so that I can do crowns and stuff at the very end. Level the occlusal planes. Maybe put the gum lines, line up the gum lines for me." And I would get back uh, something that I didn't expect. And now I don't have any room for my restorative. And I either have to send them back to ortho or I have to come up with something else. And it's miserable. It's miserable for me, miserable for the patient. So if I just sent this to my orthodontist, they're not thinking restoratively, right? Um, I want to think where the teeth are and where they should be in their proper place. And when I send this to the orthodontist and have broken down teeth, I'm asking them to imagine this. Imagine how the teeth should be, imagine where they should be, and then imagine them into that position over every time you see this patient. Remember what you've imagined every single time. And I may or may not get what I want. And my imagination may not match what my orthodontist imagination is. So it gets very difficult to for us to both be on the same page when we're using our imagination. Additionally, sometimes I will think, hey, put the tooth here, it'll be great. And then at the end of treatment, when I go to actually do the ceramics and prep things, I realize this tooth isn't in the best position for me. And then I have to start making compromises. And my case isn't ideal at the very end. And it's one of these, you know how it is. You take pictures of a case, the patient may be happy, but I look at it and I go, I missed the mark there. Or at the day you prep, your blood pressure shoots up because you're like, oh crap, this needs more clearance. This needs more room to get it where it needs to go. So transitional bonding is something that can help us eliminate those issues by making those imaginary things into actual life. Another great case. This patient has a collapsed vertical dimension. They have dentistry on every single tooth in their mouth. And I don't have the open bite, but those lower teeth are just worn and the back of the upper teeth are worn. Here's the occlusal bite. You can see acid damage everywhere and loss of occlusal vertical dimension. So this patient needs some ortho. Ideally, can we do this without ortho? I granted, absolutely, you could do this case without ortho, but you can be more conservative with orthodontics. And my goal is to always be minimally invasive. So there were other issues with this case too. And we talked to the patient. Every tooth in the mouth needs to be treated. He doesn't have the money to treat every tooth in the mouth. Ideally, we'd want some orthodontics because once we build these ward teeth down, the occlusal plane is uneven because everything's shortened. So what did we do? We used transitional reconstruction. We waxed up and rebuilt this case. And I know you can't see the height differences, but like on these lower anterior teeth on the left-hand side here, all of these teeth there's a stepped occlusion now because I lengthen these lower teeth back to what they normally should be. Same thing with the upper. These lower teeth strike the upper where he had dug into these, and there's no room. His posterior bite's open after I did this. Completely screwed up his bite. But now I have proper shaped teeth, and the orthodontist knows where to put things. And then at the end of treatment, I just have to turn it into ceramic, right? This is also a case where we took crowns off and made temporary crowns because I want to know what's under those crowns before I send them through ortho. So at the end, I can put permanent crowns on and I don't have this horrible thing where I take a crown off at the end of treatment and it's rotted out and now I have to talk about an implant. I know this information ahead of time with a transitional reconstruction in a case where it's going to be phased and sequenced over years, right? Um, this is another case right here. We have off to the left here, we have anterior wear. Posterior, we're fine. Now, pretty level occlusal planes. But we have a canted midline in the front, and these teeth are worn. So what do? We reconstruct those teeth back to the way they should be, and now we have a stepped occlusal plane. And I know what you're thinking. Their bite is screwed. You're absolutely right. I made them way worse. Their bite is messed up, but it's an amazing thing. Once you put braces on people, the bite doesn't matter till you're done. The bite doesn't matter. We're moving things, right? So at the very end, we did braces and we leveled the occlusal planes. We widened him out better for for his airway. Sorry, I got the hiccups. And now this case is stable. It doesn't look the best. You can see my bonding, but now I can talk to him about veneers. I can talk about options to make this beautiful at the very end, right? And we're phasing it over time. So with anything we do in these complex cases, we need to have a blueprint first. And this is where beginning with the end in mind is the most important part of this. This is, Covey's 7 Habits of Highly Effective People. And I really believe that having a clear picture of how you want to state the case to finish prior to touching it is the most important thing. So I use a very organized system for treatment planning, and it's using photography and templates on Keynote or PowerPoint. And I have a step-by-step system I go through to diagnose and treatment plan these cases. I do not take models, and I don't send them to the lab and say, hey, wax this up. This is all done by me. A wax up is something that I'm going to use to do the case. I do not need a wax up to plan these cases. I need a wax up when I'm ready to start so I can make my templates and I can make my stents. I used to take models on every patient and do wax ups and use it to present to the patient. And it doesn't work. You don't get more acceptance because you did a pretty wax up. You've turned everything over to your lab. Their job is to do whatever they can to make it pretty. And that wax up many times has no basis in reality. So when you start to do this case, you prep everything and try to use your wax up and realize you've just screwed yourself. Very difficult. I get cases that I have to save that come to me like this that have just been rushed because you trusted the lab. The lab doesn't know what they're doing. They're great, but they don't understand the higher level of dentistry all the time. So you can't rely on them. And then you spend a lot of money on these wax ups and you have drawers full of wax ups that you never started the case. So I don't do that. So how do I treatment plan? So diagnosing and treatment planning, I learned initially from Stephen Phelan. And I took his online course called Occlusion Design. Stephen is fantastic. And I really recommend if you want an online wonderful introduction to how to do complex full mouth reconstruction, take Stephen's course. It's called Occlusion Design. It's a year long. Every month you get a module that you go through. You take a test on it. You read through it, watch videos. And then you have a webinar at the end of the month with him where he talks through what the lesson, and additionally, you can submit cases and he will look at the case and talk through the cases with you. It's very hands-on, very, very good. And at the end of the year, you can actually go up and meet Stephen in Ontario and go to a convention that he has up there. So after I took Stephen's course twice, I took it twice. I loved it, and I felt I needed to get more out of it. I sometimes you understand things the first time, you take it again and you get even more. I get more and more out of every course I take, even when I'm auditing and repeating courses. It's amazing how much more I learn. So he was always talking about Frank Spear, and Frank Spear is in Scottsdale. And so I was like, well, geez, I'm gonna go start taking some courses with Frank Spear. He's right here. So I joined Spear Education and I began taking his curriculum of courses. And after taking all of those, now I'm visiting faculty up there and I get to go up and help teach these courses. It's fantastic. But Frank has a very organized, wonderful way of diagnosing and treatment planning cases. And it's called facially generated treatment planning. And it starts with aesthetics. Aesthetics is the appearance and position of the front teeth. That's all it is. It's where are the teeth in the face? Are the teeth in the proper place, and are they the proper shape and size, right? You start with the central incisors. And when you think about aesthetics, Frank said, hey, listen, it's pretty simple. We already know how to do aesthetics. The ultimate control in aesthetics that we have is when there are no teeth. So a patient comes in for a denture and we say, where do we put the front teeth? Well, we put it where it's supposed to go in the face. And there's research and there are rules to where teeth go. And so using photography and using templates, we can say these teeth should be here. So we plan the aesthetics and then we look at the function. And that is how the teeth relate to each other. How does the upper jaw or lower jaw relate to the upper jaw? How should the teeth be contacting in a static and dynamic occlusion? Function also has to do with TMJ health and muscle health. I'm learning more about this every day. My new path with this is neuromuscular dentistry in cases where there is pain. I struggle with how to treat people when they're in pain and when they have TMJ disorders. And I think potentially neuromuscular dentistry has a great answer for that. And that's part of my journey right now that I'm in. Um, Structure is what we do every day. It is, are they cracked, chipped, or broken? How do we make a tooth whole? Build up crowns, inlays, onlays, fillings. And biology is also what we do every day. It's, is there an abscess? Is there decay? Or is there gum disease? Right? Is there enough bone to put things where they're supposed to be? So traditionally, we did this EFSB treatment planning where we still looked at where the teeth should be, how they relate to each other, are they structurally sound, and do they have any infection? When patients come in and they have worn dentition and they've beat up their teeth and they have all these problems, we ask why. And we never had a good reason of why. Why do people grind their teeth? Why do they have these ugly smiles? Why do they have these non-functioning smiles and all these structural and biological issues? And we didn't have a good answer for all this stuff. We called it genetics, luck of the draw, bad luck. Early on, Jeff Rouse was talking to Frank Spear and started to introduce a new concept that could help you explain why things were happening the way they were. And that is airway. Airway, a troubled airway. The most important thing you do in your life is you breathe. And if you can't breathe, you will do anything to take a breath. That is what you do all the time. So when we have altered breathing, when we are developing, our bones and soft tissue don't go to the right place, and we end up beating up our teeth trying to take a breath. It sounds crazy, but it's true. And so if we go back to our denture analogy, aesthetics is putting the teeth on the, on the base plate in the right position. But there's always a step we do before we start placing teeth, and that's the wax rim. And that is what airway is. We put that wax rim and we make sure it's correct in the anterior, posterior, and transverse dimension. We make sure it's wide enough and forward enough for lip support. That is airway. It is the height and the anterior posterior position of the maxilla, maxillary ridges, and the mandible. If those are in the right place, we have room to put our tongue and we have room to breathe. So airway began, airway changed the way I look at dentistry. And I do a lot of airway prosthodontics is what I call it. I have a lecture on this too. So like I said, airway is looking at where that tooth, the wax rims are the bones where they're supposed to be. Can we breathe properly? Aesthetics is, are the teeth in the right place and the right size? Function is how they relate to each other. Structure is, are they whole? Do they need something? And biology is, are they infected? Is there a problem? Now, when we do this diagnosis and treatment planning, we plan airway first, right? You have to build the foundation of a house before you can build the house. So we plan the foundation first, and we talk about that. If there's foundational issues, we need to talk about them and talk about what we can do to make them better. Now, a lot of people, when they see this, they go, you're going to do all that before biology, before tooth infection. We treat the opposite way. We're always going to treat biology first, right? But if a tooth is not strategic in our plan, are we going to do a buildup and crown on it if we plan on extracting it anyway? Right? You need to know these things ahead of time. So this is where Spear excels, is in this treatment planning and presenting this treatment to the patient so the patient can understand it and they can say yes to your treatment, or we can figure out what they say no to and what that'll look like. So in my treatment planning, I have a very detailed interview that I do with our patients. We take, just like everybody, a lot of radiographs. I try to get a 3D CT whenever possible. And the big thing is we take a lot of photos, and I'm going to go over those photos. The records that I take are very involved. They, I mean, I'm literally measuring the teeth in the mouth. I'm taking a lot of measurements of the face, and there's a research to back up these measurements of where should the teeth be and where they are. Um, and then we're going to do our observation and test just like everybody does. And the nice thing is when you split it up AEFSB, you measure and you do these things in a very organized way so you never miss anything. Again, I said I don't do a wax up on these cases. So here's some of the extra oral photos I take. It starts with repose, smile, lateral. Always make sure you can see the ear because this is how you get the allotragus line. I'm looking to see if she has a forward head posture. I'm looking to see if she has mentalis strain when she closes her lips. This is a great photo because I can correct all my other photos. I'll go over that in a second. So you're going to take a bunch of extra oral photos, and I don't take these photos. My assistants take them, but I have to make sure they're clinical photography, not fashion photography, right? Because I'm going to use these to treatment plan. Here's my wonderful example. You take this photo, we have teeth together and teeth apart so I can see the incisal edges, and you look at it and go, oh my gosh, she's damn near perfect, isn't she? Look at that. Incisal plane level, no canted maxillary midline, looks fantastic. Here's the problem. That's not her. When they looked through the viewfinder, they lined up the little X so that they could see the lower teeth, and they put the little thing right over here and they took that photo. It looks fantastic. But when you look at her face and relate her teeth to her face, this is her. She has a canted incisal plane. She has a canted midline. She has a canted occlusal plane, right? But because we took the wrong photo, I couldn't treatment plan this case properly. So this photo helps me out immensely because I can see here she's canted. Look at her and look at her. And I love her eyes drooping. It's fantastic. Like no one looks good in these photos, but I can take what's her pupillary line, what's her midline, right? And I can see that there's a cant. So if I have this photo, I can then focus in on it and I can make a little template here and draw over the incisal edges and draw that yellow line through the midline and record that cant and then take that and put it on these other photos. And I can see, look, that doesn't match up. Midline doesn't match up, incisal doesn't match up, and I can correct them. I hate doing this. And whenever I do this, I will bring my assistants in and I will talk to them as I do this and tell them what I'm having to do to fix this photo. And then it happens less and less. So there's ways to fix this, but we really want to make sure we get photos that actually represent what we see in the patient. So there's a bunch of other photos we take. We take lips in repose, full smile. So if you look at these two ones up here, when I told her to smile, she smiled here. She doesn't show any gums. Isn't that fantastic? Slam dunk case, no gums. Tickle her and look what happens. Tell a joke and look what happens. So I always try to get this spontaneous smile because if she doesn't like her teeth, she's going to guard her smile. And then once I make her smile big, she's going to show her gums. And if I didn't address that ahead of time, it's a bad surprise at the end of treatment when she starts smiling bigger. Other photos we're going to get for occlusal plane and the bite. And then I'm going to take my aesthetic records. I'm taking measurements of the face. What are the facial heights, mid and lower face? How much of the central incisor is shown at rest when they just are resting their face and they have that freeway space and they're breathing through their mouth? There is a norm there. And it could be different for each tooth, so you can record it for each tooth. What is their lip length? If they're not showing any front teeth and they have a long lip, am I ever going to have them show teeth? No. Or maybe they smile and they show a ton of gum tissue, but when they're not smiling, everything looks normal. Do they really have a gummy smile or do they have a hypermobile lip? Maybe I can just Botox it a little to help deal with that. How much gum tissue are they showing? That helps me detail the risk of the case. If someone cannot show any gum tissue, do I need to line up the gum tissue? Do I need to line up the gingival architecture? Maybe not. Maybe this is a lot simpler. Can I feel and palpate the CEJs? We'll talk more about that in a minute. And then what are the tooth proportions? Measure the height and width of each of the anterior teeth and record that. And there are ways to calculate tooth proportions that we'll go through. For instruments I use in my exam, I have digital calipers. I also have different measuring tools, and I have a leaf gauge. Leaf gauge is going to help me determine, is there any TMJ problems that, and I'm going to listen to the joint. I even have a Doppler where I can listen to the joint sounds to see, are there pops, clicks, grating, something going on that I need to maybe open up that functional bucket a bit more if someone's having issues and dig in there. I'm not going to restore somebody with a messed up TMJ and muscle pain. I need to stabilize them if I'm going to restore them. Um, oh, I just spilled wine over everything. Hold on just a second. I got to clean up wine. All right. Well, that was frustrating. I'll clean it up more later. This is a good glass of wine too. All right, let's move on. Jesus. All right, let's talk about tooth proportions. Um, this is, I think, from Dr. Chu, Stephen Chu, talking about height and width ratio. There's multiple ways to calculate this. I like to go off the actual width of the tooth. There are golden proportion rulers. Golden proportion tends to make you too narrow and too long. Some people will argue for that, and it's great to measure it and look, but ultimately I'm going to look and see, does it look okay in their mouth? And like I said, golden proportion tends to be too narrow and too long. So there are ways to calculate what the proper size of the teeth should be. Here is another calculation from Dr. Chu right here. And honestly, I try to keep it as simple as possible. An 8 millimeter wide central should be 10 millimeters long. An 8.5 should be about maybe 11 millimeters long, and a 9 millimeter is 11.5 millimeters long. So whatever you're going to do to figure out the proportions of a tooth, if you measure the width, now you can calculate what the normal height should be. There's not a lot of width issues in centrals. You can find them, but generally central incisors have about the right width that you need. Laterals will not. So when you calculate your laterals, you can get that lateral off of the central. But calculate, what should my height be? And if you are short, you need to figure out why that anterior tooth is short. You're going to look at wear. Is there wear on the edge of the teeth? That's easy to see. If a tooth is short and it's worn, pretty easy, right? If it's supposed to be 10 millimeters long and it's 8, you've lost 2 millimeters. Something people sometimes miss is palpating the CEJ. Go over the gum line, under the gum line, and see if you can feel the CEJ. For people with gummy smiles, sometimes it's not that they have worn teeth. It's that their gums, their tooth never erupted properly, and you have altered passive and altered active eruption. We did this in dental school. It didn't make sense to me at the time. For some reason, it didn't stick. But as I started doing aesthetics, this made a lot more sense. So if you cannot palpate the CEJ and you have a short tooth, there's a chance that the bone is too close to the CEJ, and the gum tissue standing on top of that is making this tooth appear short, right? Especially in cases where you have short teeth and no wear. The next one is altered passive eruption. And this is where you can palpate the CEJ, but there's a lot of gum tissue right there, right? And the gum tissue never receded like it should have. These are great gingivectomy cases too. This is where a gingivectomy will work. These other ones, with altered active eruption, you need to do some time of either aesthetic or circumferential crown lengthening. You need to talk to your patient ahead of time about this too, that they have this condition and this is why the tooth or a couple teeth are short. You can also have both of these happening at the same time. And I will say that these Gingivectomy only altered active eruption or altered passive eruption cases are very rare. So both can be happening at the same time, and they can be coupled with wear. So a good diagnosis of tooth length, and it's important in transitional reconstruction because we're going to be calculating this proper tooth length and width. We need to know, is part of this tooth hidden under the gums that we need to address it with the patient? Because sometimes you'll start doing ortho and the bone and the gum tissue will recede and expose the tooth. And now if you thought it was only where that was happening, you have a tooth that is a way too long, right? And what's that going to look like when it comes back from ortho, right? We need to talk about wear, type, and extent. And we kind of split wear up into a couple things. When we look at the normal presentation of teeth, we should have whole teeth, and teeth should be gently sliding over each other. They should not be running into each other and wearing each other out, right? So one of the most common types of wear we're going to see is edge to edge. And this is where the lower teeth have worn the edges of the upper teeth, and you see these flat wear facets, right? And as teeth wear, they actually move into each other many times and will have compensatory eruption. So a lot of these cases, you'll see the gum line will fall down on the anteriors and you have these short teeth. And if you lengthen those teeth back to where they should be, they're in the wrong place in the face, and the gum line, the gum architecture is wrong. So this is wear with compensatory eruption. We need to lengthen the teeth and push them back to where they were, or we need to do circumferential crown lengthening and crown the teeth up to that where the gum line should be. Pathway wear is a very destructive one. This is where the lower teeth are rubbing over the surface of the upper teeth, and you have wear on the lingual of the upper and the facial of the lower. Very destructive of the teeth, and we end up ratcheting in, losing that anterior coupling and having the teeth collide into each other. These are the people that have these front teeth that just have, you can see through the enamel. It's one little piece of enamel on the front, and their lower teeth are sharp and just sit up and are biting into their palate. That's a pathway wear case that leads to a deep bite. You can have crossover wear. Crossover is when, in function, we end up moving out beyond the incisal edges and actually jumping the arch and wearing on the opposite side. And you can have all of these going on at once. You can have it, and you can have it in different places. You can see it just in the anterior, you can see it just in the posterior, or you can see it generalized. And like I said, and you have to figure out why they wore away too. Was this attrition, tooth to tooth? Was it erosion? Was this biting on something or acid damage, biocorrosion? Or was this abrasion? You know, are they chewing on something and damaging their teeth? And the very frustrating things is all of this can be happening at once. You can have pathway, edge to edge, and crossover with attrition and erosion and abrasion, and it can be everywhere. By labeling this, we can know some of what is causing this and start talking to the patient about it. And many times, this is going to lead you back to airway. It's the king. So with our photos, I take a full face retracted. This will help me get my midlines and occlusal planes. I'm going to take my profile and I'm going to line this up by the ala tragus line. And I'm going to see, is this patient in a head forward posture? People that are in a head forward posture tend to have airway issues. A lot of times they have TMJ issues, and they have posture issues that's going to affect their bite and their teeth. I'm going to correct the photo and I'm going to drop a line from the forehead down, and I'm going to see are the front teeth on that line. This is called Andrew's line. This gives me an idea, is the maxilla in the proper anterior posterior position? If you do this and the teeth are a full step behind, these are people who are maxillary and mandibular retrusive, or sometimes their lower jaws where it's supposed to be, but the upper jaw's back, and then we have a mid-face deficiency in a class 3 representation, right? I'm going to measure soft tissue angles from glabella to nasion to poignyon. When I take a protractor and put it on that, it should be between 165 and 175 degrees. People who have a class 2 representation will have a greater, a lesser angle at that. People who are mid-face deficient will have a more flat angle. So this is another one of those things that can be coupled to say, are the jaws in the proper anterior posterior position for the head? And is there an airway issue that we may want to address with this patient so they have better quality of life? I'm going to measure facial heights. Again, with airway and mouth breathing, we will have a longer lower face than the mid face. And if you have a long lower face, are you going to add to these teeth and increase the vertical dimension, right? What's going to happen if someone with a long face, if I make it longer, right? I'm going to look with the tooth closed, and you can see she has mentalis strain. She can't close her lips the way they want to. She has excessive display at rest in her front teeth. She has an airway problem, and all her teeth are whole. They're where they're supposed to be. So is this somebody I'm going to reconstruct? No, we're going to talk about oral surgery. We're going to talk about surgically facilitated orthodontics. We're going to talk about other things that can help her be healthier and put her teeth where they're supposed to be. I'm going to look, here's the incisor display at rest. Normal is 1 to 4 millimeter incisor display at rest. We measure this on our patients. I'm going to measure the lip length and the lip mobility right there. And I'm going to measure how much gum tissue is displayed in her smile, right? I'm going to look at the buccal quarter. Now we're starting to get into transverse. How wide is the upper jaw? Is it too narrow, right? And a narrow upper jaw means a narrow nose where you can't breathe. I'm going to look at the E-bite to look at gingival symmetry and incisal edge symmetry and the papilla symmetry. We're going to look at the occlusal planes to see if they're level, upper and lower. And then I'm going to look at the width of the maxillary arch. Maxillary arch, if it is less than 50 millimeters, is it 40 millimeters? I think it's 40 millimeters. That is a very diagnostic for potential breathing issues. In your office, you have a cotton roll. That's about 40 millimeters. So if you cannot comfortably put a cotton roll in someone's maxilla, they're narrow. Lower teeth, I'm going to look for lingually tilted lower teeth. The lower jaw tends to grow the way it's supposed to. If the upper jaw is retruded, we end up getting crossbite, right? Bilateral posterior crossbite. The lower teeth want to be in occlusion, so they will tilt in. So when I see lingually tilted lower teeth and not a nice big horseshoe jaw, I know there's potentially an airway issue. Based off all of the stuff that you learned, you're going to come up with some sort of diagnosis. Wear with compensatory eruption, eruption without wear, altered eruption, wear and loss of VDO, maxillary anterior posterior insufficiency, all of these things. And there can be all of them happening or multiple things happening at once. So when we discuss our patient, what the problems are and what we want to fix, we know what treatments affect these things, right? And we know that there's certain things you don't want to do. If someone has excessive display because they have a short lip, you're not going to want to do a maxillary impaction. You're not going to want to do these things. So it helps guide you in what treatments are available for the patient. And I use templates to show where the teeth should be. Where ideally should these teeth be in the face? And now I can start to conceptualize how I can get them there. And I use these templates to communicate with my specialists. This is where I want things to end up, right? And the lab too. With the treatment presentation, we do a tour of the mouth, present the problem list, and then we just start discussing how we're going to correct this. This is what's so powerful about this is I don't hand people a treatment plan anymore. I talk to them about what is available to them and what they want to fix. And if they say no to something, we talk about what that's going to look like, right? Because whenever you say no to one thing, you say yes to someone else. And a lot of times when I do it this way, it's not about that they can't afford it. It's about how they afford it. And maybe they can't do it all at once. And so this is where I can talk rather than changing my plan. Let's talk about phasing and sequencing it so we can get you what you want, what I want, something that's stable over time and makes you healthier and that you can afford, right? So when you do this transitional bonding, so we're going to talk about cases, the cases where I use this many times are where I need some orthodontics. I need to level the occlusal planes because the teeth are worn and they're in the wrong position. When you do this transitional bonding, I need to send them to the orthodontist first, or not first, but after I talk to them and get them on board. And if they say, yes, I'll do it, I want them to see the orthodontist. I cannot do transitional bonding in the absence of ortho or the absence of whatever specialist I'm going to use. So I also write a letter and I instruct them, do not start the case. Do not start this case because I ask specific questions and show them what I want to do. So I write a letter and I don't have them scheduled with the specialist until the specialist has my letter, has my PowerPoint, has my templates, and I've had a chance to talk to them. Um, and we're going to get a discussion of what our plan is with this because they're not used to doing cases like this. They're used to things being handed off to them. Once we come to agreement, I'm going to write another letter to all the specialists detailing everything that I want to do, right? And that the appointment day for transitional bonding, I will do my transitional bonding. Sometimes I place bite stops or I have them go over to the orthodontist that day or next day, get scanned or get the braces on, and then bite stops will be placed so they have a stable occlusion. All right. That's all the treatment planning part of this. And I know I kind of rushed over that. Go take some good courses, go take the SPEAR courses, learn how to do aesthetic treatment planning. So when I have a plan, I need to make it real, and that's going to be waxing. Whether I do digital or physical waxing, I need to wax these teeth up. The waxing needs to be additive only. A lot of times when you send stuff to a lab, they're going to buzz the tooth away and then wax it up to make it look perfect. If all I'm doing is adding to teeth, I can't buzz the tooth away first. Otherwise, my template's not going to fit. So don't do any adjustments to the model. Build everything on the way the model is, right? You want to leave tooth structure, virgin tooth structure, for positive stops for the matrix. If they wax the entire tooth up, then my template goes in and it rattles. It doesn't have a place to be and nothing fits. And it doesn't look good to have a lot of adjustments afterwards. The next important thing is I want to make the teeth the proper size and shape, but I need to follow the arrangement the teeth are in. So if the teeth are overlapped and crooked and they're worn, I'm gonna wax them up and I'm gonna make them overlap again, right? Sometimes you don't get the prettiest teeth when you do this, but you have to look at your CBCT, you have to look at your x-rays, look at root angulation, look at the tooth and figure where would this tooth be if it was whole. Don't correct things when you do this. You're going to correct it in your ortho. It will look worse. I always tell people, I'm going to make you uglier before I make you prettier. That's all there is to it, right? You have to warn them of this. Most people are accepting of it, but I'm going to make you look worse. And I'm going to mess your bite up too. So here's my waxing kit. I have all these instruments. I'll show you the instruments I like to use. The waxer I have literally is off of eBay. It's cheap as hell, but it works. There's more expensive ones if you want it. I bought the cheap one because I didn't have money at the time, and I've used it forever. I like gray wax, not the white wax. If you have white stone, wax it up gray. If you have gray stone, wax it up white. You want to be able to see where your wax is beginning and ending on these cases so that you know you have positive seats, right? I wax mainly with a half Hallenbach carver. That's my main go-to. I also like this sickle scaler because it's rounded. And when I do my, the rounded parts of the tooth and the line angles, that sickle scaler fits it beautifully. And the edge is very sharp, so I can do nice little details. I also like this CompuSculpt. CompuSculpt is very fine. I can do incisal edge details. I can do my incisal embrasures, and I can do surface texturing with this. I love. And then a blending brush. Steal it from your wife or your spouse, or buy one off of Amazon. I keep this in my hand between my fingers here, and as I wax, I take the blender brush and I brush the wax off. No more and blowing on people's models, right? Use the blending brush to brush your wax away. So the steps to waxing are, you have the tooth heights and proportions that you want the tooth to be. You measure from the gum line to the incisal edge and figure out how much white wax you need to add. Add the wax to the incisal edge. Sand it down to get it right. Add to the mesial and distal if you're adding width. Extend it slightly down the facial and lingual to get the proper thickness of the tooth. and then just carve it out to match the arrangement. It's relatively simple. You're going to do some bulk filling, and then you're going to carve it down. So here I am on these two central incisors. I'm adding wax to bring them up to the proper height on the incisal edge. Now I'm going to measure and I'm going to sand those down with some sanding paper to get it to the proper height. And then I'm going to use my half Hollenbeck carver to get my anatomy. I don't and a little bit on the facial. This does not have to be perfect. You're going to do this in the mouth again by hand eventually, and you're going to carve it up and polish it. All you're doing is gross shape here. You want the proper height, width, and the basic anatomy correct. If you send this to a lab, you're going to struggle. Labs don't know how to do this type of transitional bonding. They're used to making things look good, and this will look worse. They're not used to reading letters on how you want something waxed up. I have worked with so many labs to try to get them to do this because I do this work. I do this on the weekends. On a Friday, on a Thursday, I'll bring my waxing stuff home and watch a TV and do waxing really quick. They can't not put something in occlusion. So even if I tell them, listen, ignore the occlusion, they can't do it. I've gone so far as to try to send two separate cases. I send the upper as one case and the lower as one case and say, wax this up and wax this up. And they somehow find those cases and they put them together for me. And then everything comes back in occlusion. I don't want it in occlusion. All right. I'm messing up the occlusion on purpose so I can get it right later. And they have trouble not making it look good. They're going to wax up the entire facial of the tooth. They're going to use the wrong kind of wax, even if I send them the wax, because they're not used to this. They don't have dark wax. They just don't have it. Everybody wants the white, pretty wax. They don't have it. And they don't know the root angulation. Even if I send them a CBCT and an X-ray, they don't understand root angulation like we understand root angulation. So here's a letter that I sent to the lab telling them step by step what I wanted to happen. And I got it back and it was wrong. And so I wrote another letter and I sent this to the lab telling them I corrected the wax up, and they sent it back to me wrong again. And the day I got it back, this is the case. And I'd already messed with the wax up here, but this is how they wax it up. They made everything flat and perfect for me. And on the back teeth, they completely waxed up the whole back teeth. Look how thick those things are. They corrected all, they did the ortho for me. This patient is going to ortho, right? There again, there's no positive stops on this whatsoever. I had to grind it all off. So I sent them pictures. I said, here's what you sent me. That's what I wanted. I wanted it to look worse. I wanted the bite to be messed up. I wanted the height of those things to be proper. That's what you sent me. That's what I wanted. This is just occlusal stamps on these teeth. I'm just rebuilding the occlusal table, and I need to have a positive seat on the buccal and lingual. The patient was coming in a half an hour. I had to carve this stuff as fast as I could. Digital wax ups. If you send it to your lab for a digital wax up, the first thing they do when they do a digital wax up is they delete the tooth. They go in there and they select the tooth, they delete it, and then they place a new tooth, and they try to put that tooth in the proper position. This is something I think I got off online. So don't worry about the patient's name. That's not my patient. But they delete the tooth completely, and they just set the teeth wherever they want to be, where they look good. And a lot of times that pays no attention to where the actual tooth is. So you'll go to do this wax up, and you'll expect the tooth to be here, but they waxed up the tooth over here. And now it doesn't fit, and your wax up doesn't relate to the roots, right? So the stents are also very difficult to fit because sometimes they'll put the tooth farther back than the real tooth was. So you go to slip it over, and the stent your stent for additive wax up doesn't work. So digital additive wax up is very difficult to do. I do digital additive wax up. This is a case that I did where I don't delete any of the teeth. I make my margins where I want the margin to be, and then I add wax to those. So that's my additive wax up. Right there, I'm selecting the margin around the tooth like that. And then I will seat this digitally onto the case so it's additive. This is another where I did additive wax up and I actually printed these onlays for the back teeth. And you can see them on the print plate there. This is the new way I've been doing this because doing it by hand is very difficult. I'll go through both methods. So here's my recommendation for waxing. This is a temporary thing. It's transitional. You can do it. You can do this. You did it in school. You can do it again. The wax up is practice for doing this in the mouth. You're going to have to do this in composite. Do it in wax first. You figure out the problems, right? You know where it's supposed to be. If you do it in wax first, you know what it's supposed to look like. You did it. Incisal edges are the most important part. You can do incisal edges. You don't have to make it look good. You just need to get basic shapes right and then polish it because they're going into ortho. Don't let perfect get in the way of good. Just get it done. Just get it done, get the basic shape right, and get it done in the mouth. When you do these cases and you're doing bonding in an entire mouth, it's a decent amount of money for this patient, right? But it's not crown and bridge money. So if you start putting a lab bill to it, you're getting paid less per hour and you're going to sit at the end of the day going, why did I do that? I could have done something else, right? So you're going to charge well for these cases, but it's not lab bill well. So if you do the work quickly, you save yourself that lab bill. Do a really crappy job of it to get it the way you want and send it to the lab and just negotiate a price for them just to clean it up a little, right? And make it a little prettier if that's what you want. And maybe make your stents. You're going to have to babysit them the first couple times though. Train an assistant to do it. You have assistants. They love doing this stuff. Empower your assistants. You're going to have somebody who's really good at this stuff. They're crafty, right? Have them do arts and crafts for your patient. And always remember, the first step in being good at something is sucking at it. Do not be afraid to be bad at something or you're never going to get good at anything. Go in there and be a little bad at it and figure it out. Be committed to continuing to get better at it. But you'll never get better if you don't start. So do your own wax ups. All right. So now we have our wax up and it's all janky and the teeth are in the wrong place. And we need to somehow transfer that to the mouth. We're going to do these with guides and stents. And I'm going to go through the different guides and stents that you would use to help transfer this plan and wax into the mouth. The first one, and the one we all know about, is this putty wash. It's readily available, easy to use, relatively accurate, and the advantage is you can make this over the wax up. So you're going to have a putty and a light body wash. I recommend when you do this, you get some perforated tray, non-perforated tray. Perfilus, that's a weird word. I don't think it's a real word. Non-perforated trays. That way the stuff doesn't go through the tray. Don't put any of your PVS bonding agent on the tray. Put your putty in, depress it into the teeth, put your wash over, push it down, let it set up and pop it off. And now since you have that non-perforated tray, you have a nice margin for this thing, right? And you can trim it up. What are the downsides of this? The biggest downside is you can't cure through this. So if you're going to use this, you have to use a self-curing material, which is generally going to be a temporary material, and it's going to be weaker. It's going to be weaker. It's not going to bond the way you want it to bond, and it's not going to last as well. So I find these things not as strong as composite. And so I don't like them as much, but that's one way to do it. The other thing you're going to have with these PVS putty washes is you're going to have an oxygen inhibition layer. So when you bond composite or everything to this and you let it set up or you hit it with a light, you pop it off and you go to feel the composite or the temporary material, it's gummy. And that's because there's an oxygen inhibition layer and you have to clean that off with something, or you have to put glycerin on it and cure through it to make it hard again. So I don't use these as much, but they're useful when you're doing the traditional rebuilding a front tooth, making a palatal shell and layering in, right? A hint for this is when you do these, put them in a non-heated pressure pot and it'll drive the bubbles out and they'll be harder, stiffer, and better for you, right? So here's I just have a pressure pot from Great Lakes Ortho. I put it over that. I don't heat it up. You're going to melt your wax. Put it in there, and it'll be a lot harder and more sturdy. This is from Great Lakes Orthodontics. Don't buy the cheap one off Amazon or eBay. They'll blow up. And I know that because I almost lost a hand because of these things. I blew one up into my hand. Thought I'd destroyed my career. Scared me to death. This is one I use a lot. This is a clear silicone matrix. So Seal 2 or Elite Glass, there's a couple different ones, but this is silicone. And so you're going to be injecting this over your wax up. You can also do this over this wax up because it doesn't heat up and it's going to set up. The advantage here is it's easy to use. You know how to use PVS. You have all the instruments for this. You can cure through this. So for injection molding, very, very useful. There's no oxygen inhibition layer. This is silicone. So when you pop this off, it's like a Mylar strip smooth. Beautiful. And like I said, you can make this over a wax up. This is really difficult for small placement. You need a bit of bulk in there. So if it's just little placement, I'll talk about how I do those. I say you must use a flowable composite. I don't say that anymore. I actually use heated packable composite now, but I also, and you end with flowable, but you can do this with a flowable composite. That's traditionally how it was done. Again, a hint, use a non-perforated tray, and I'm going to show you how I make these. I take my model, and in the tray, I put some bite registration material on the back teeth, and then I set it into that model so it's suspended away from the tray so I have the proper thickness, available room for thickness. I then inject this onto the teeth really well, and I inject it into the tray and then push those together, seating it into my posterior bite stops of the bite material. I then put it in a pressure pot, again, a non-heated pressure pot, so that it drives all the bubbles out. This gets way more dense and there's no bubbles in it whatsoever. They're smashed flat in the pressure pot. Now you can see when it comes out, I have this beautiful, even, clear. The one on this side, the blue one is Seal. The other one is this Elite Glass. I like Elite Glass better than Seal. And then I'm going to poke holes in this. And the way I do it is I go from the inside out. And the reason is this. It's going to break sometimes. And if you do it from the outside in, you're going to break what you wanted to build up. Additionally, now I will make this hole and then I will take a KS2 burr diamond and I will drill it out a bit more, just the size for a heated packable composite capsule to fit into. All right, so that is the what's it called? The clear silicone matrix. I'm forgetting my words. And there's some other really cool things I'll show you can do with this in a minute. 1.5 millimeter Copyplast. I love Copyplast. I use this for a lot of my temporaries. I use it for my temporary veneers. It takes a Mini Star by Great Lakes, great machine. This is like the old suck down things, but this actually pressures from the top down. So it pressures things over. This is a 1.5 millimeter flexible material, and you cannot do this over your wax up. It will melt. So you have to duplicate your wax up in order to do this. Or if you have a 3D printer like I do, 3D print your wax up. You can use filled composites with this. It's hard to use for injection molding. So you have to drill through it and you get all this little weird stuff. But I'll show you the different cases that I would use this one over a wax up, but you have to dupe your wax up or you have to 3D print it. So what do I use when I'm bonding? First thing, you have to get air abrasion, 50 micron aluminum oxide and air abrasion. I have one of these in every single room and one in the lab. I air abrade absolutely everything. You need to clean that tooth off. You need to clean the enamel. It'll also blast out little cavities and everything, which is fantastic. You need an adhesive. Now, when you use the bottled adhesive and you drop it into a container, and then you work one or two teeth at a time, that thing dries out and gets gummy. So I use this universal adhesive pen I believe this is by Ivoclar. And that way, each time I work to the next tooth, I just have to click that and I get fresh bond. and I don't waste a lot of bond because bond is really expensive. So I do recommend this pen. You need heated, flowable, and packable composite. And this is what I use. This is the Calumet. I love having heated composite. Everything I do is heated composite. Um, Heated flowable too. It goes, no more bubbles. It goes where you want it to go. I like this modeling resin by Bisco. When I am doing certain things and pushing composite, I don't want it sticking to my instrument, and I don't want to use bond. Modeling resin is what I use to wet my instrument to push things around. When we talk about staining and glazing, I use the Creative Color Tints by Cosmodont to do my staining and glazing and characterization. You can use these if you make provisional veneers. You can color your veneers with these things. All my temporaries, no one goes home with a tooth number 9 temporary that doesn't look like number 8. I do all my correction there. Patients really appreciate it. What composite are you going to use? If you're going to use flowable composite, I use packable composite. Some people talk about hybrids being super strong, and then you have microhybrids, microfills, and nanofills. The highest failure rate is going to be with the microfills. They're just not strong enough, but they're very polishable and beautiful. With hybrids and microhybrids, they're very strong, but they don't hold their polish. So some people will use a hybrid on the lingual, a microhybrid for strength, and then microfill on the front. That's too many things. It's too many things for me. Nanofills solve everything. So just use a nanofill. We have them now. There's nanofilled composite, flowable composite. We have what I use, which is the Filtech, Tetric Even Flow, Clear Film Majesty. A lot of people use that for injection molding, or the Herculite Ultra Flow. I use the 3M products, Filtech, for my packable composite and my flowable, so it all works together. All right, now we're going to get into the methods of transitional bonding. This is a place in California by the Salton Sea. It's real. It's in Grand Theft Auto 5, and we made a trip around the Salton Sea just to take photos of all the places in Grand Theft Auto 5, including the prison. It was pretty cool. So what are the methods for transitional bonding? There's a freehand method. There's traditional lingual shell and layering. I don't do a lot of that for this. There's a Marshall Hansen bulk fill. If you've not taken Marshall Hansen classes, you need to take it. Injection molding, copy space placement. There's an indirect with a Park-Held product I'll show you. And then there's 3D printing and milling. And I use all of these things at different times. So a freehand addition. Freehand addition is basically I'm taking composite, putting on the tooth, sculpting it, curing it, right? It doesn't need a stent. For minimal small things, it's really good. I use it on non-functional cusps or even functional cusps that have like divots in them and stuff, or use it for repairs. The disadvantage is if you do it first, your stent's not going to fit. So if you're going to do freehand on any teeth, it's the last thing you do. When they get larger, you're becoming this artist with freehand artist, and it gets difficult to make it look right, and everything will start to slump too. If you're doing something in someone's bite for transitional bonding for phasing a case, you're going to have a lot of adjustments because there's no way you can freehand into occlusion. You're going to just be adjusting like crazy. So let's talk about the lingual shell. This is what you learned in school. It's the traditional clear palatal shell, layering in some mamelons, putting in your tints, putting a clear layer overhead. It takes a lot of time. It gives you all this beautiful aesthetics and everything, but they're going to bond a bracket onto this, or they're going to put a bubble on it. And when they take it off, they're going to destroy it, right? So if I have one central with no bracket and they're doing aligners, I might do this. But the other hard part of this is the thickness, right? You put your palatal shell, you put your mamelons, you put this other stuff, and then you put it out, and then it's too thick and you carve it back and you lose all that clear layer. Very difficult to do this. I don't even do my class 4s like this anymore. I have a different way to do them. And this doesn't work on posterior teeth. So I don't have pictures of me doing this on patients because I have a busy practice and I don't have time to take pictures of what I'm doing. So I did this on models. So here you take, and it's not very good work. I was trying to do it quickly. So lingual stent, place that, get it about the right shape. You're going to add in your mamelons, put in anything, put a clear layer over the top, and then polish. This is going to be hard for transitional bonding, right? Because you got to work one tooth at a time, and you just don't have time. You don't get paid enough to do transitional bonding like this, one tooth at a time. Bulk fill method. This is the same as that, but rather than doing just a lingual stent, I'm just going to put all of the composite as a body shade and just wrap it around the front, right? Because all I really need is that shape. I'm just going to wrap it around the front. Now, let's say I don't like the way that looks. And this is how I do my class fours now. I will do it this way, or I'll injection mold it. And then I do what I call an aesthetic upgrade. And I charge for this. I carve out a little swimming pool in the front of that tooth. And then I layer in my mamelons, put in my tints and opaquers, put a clear layer over the top, polish it. This way, when I do that bulk fill and I adjust the bulk fill, I get the shape of the tooth and the width of the tooth proper. And then when I carve in, I know I only have to add back what I carved out, and that final layer is beautiful. I can have that clear layer over and not have to worry about polishing it off. Marshall Hansen teaches this technique along with a lot of people at the ACD. This is Marshall Hansen. This is the work he does. The guy is a god. Take his class. It is so worth it. It is hard work, though. It is tough, but it's beautiful and it's minimally invasive. So you're also going to go, and if the mesial and distal of this tooth needs adding, you're going to add it if it's too narrow. And to add to the mesial and distal, I'll use BioClear matrices. There's also this Unica matrice that I'll use. And this is kind of how these work. The BioClear slips down and I can now bulk fill the mesial and distal, right? The Unica band works similarly like this, where I can wrap it around that tooth and I can get the mesial and distal and even build up the facial with this. You can also just use a little Paladint and slide it in between the teeth and get that shape. You don't want to use a flat matrix band because you're not going to get the contours you want. Then I'm going to bulk fill this tooth. Once I get the mesial and distal right, and I have the incisal edge right, I'm going to wrap a mylar strip around the tooth and shove it under the gums. I can even move the gum line with this. This is what Marshall Hansen teaches. And then I'm going to go in and I'm going to put bond and flowable composite and packable, and I'm going to build up that entire tooth. And now I have a very funky looking tooth, right? But it's bulk filled. It's all one color, one shade. And I can then go down and very quickly cut 3 planes of occlusion and get a proper looking tooth. And it's going to be monochromatic. And if I want to, I can carve out my swimming pool and do my aesthetic upgrade. But what I do is I do this, they do ortho, and at the end of ortho, I will do my aesthetic upgrade. I won't do it at the time of transitional bonding. It takes too long. Injection molding. This is where I'm using that clear silicone or PBS of the wax up with that hole. And I'm putting warmed flowable composite injected through the hole and cure. And like I said, now I'm doing warm packable composite. You work one tooth at a time, or you work every other tooth. And what I love doing now is I 3D print. I do digital wax up and I 3D print them, and I'll make 2 stints. One stint with all the teeth done, and then one stint with every other tooth waxed up. So that I will do the every other tooth first, shape it, and then pop on the stint with all of them and do the other teeth. I'll show you what I mean. I'm using that composite, very quick and easy to do. It can be used both anterior and posterior, but usually is in the anterior. This is what I use a lot. So here's a case. Isolate that tooth, and you see how my matrix, the silicone fits over there, but I left the Teflon in. The problem with leaving the Teflon in is it's going to roll. So you actually don't want to leave the Teflon in, right? You want to seat it without the Teflon. And all these other teeth are polished nicely and clean. And I'm going to inject my composite in there, cure it. And when it comes off, I have these little lips. I take a barred Parker blade and I trim them off. And then I polish it. Here's one where segments will wax up. So on this side, every other tooth is waxed up. And I injection mold those first. And after I shape them, and then I have another stint where every tooth is waxed up, and I do the ones I didn't do the first pass through. I can get in two things. I can do all six anterior teeth in two passes. Literally takes 20, 30 minutes. This is useful. It's called a Parkell indirect method. What we're doing here is we're using this Parkell Mach 2 disilicone, right? We're going to pour up an impression of the person's teeth with this. And we're also using blue mousse to serve as a base for that silicone, right? So I'm going to make my wax up and I'm going to make my matrix. Usually my matrix is going to be a copyplast or a silicone, right? This is useful, especially in the posterior. Like I can do a whole quadrant in the posterior if I have decay or old filling materials. So now I'll go in their mouth and I'll remove the old filling materials and I'll remove the decay. I'm now going to take an alginate and inject it into those areas and really mash it down and take an alginate of the prepared surface of the teeth. I'm going to take that alginate and I'm going to use the disilicone to inject it into where the teeth are to pour up the model in disilicone. And then I'm going to use the blue mousse over the top of the disilicone. Realistically, the reason you're doing this is because the disilicone is expensive and I need to have a base. So I'm only going to pour the teeth up with the disilicone and then over that put the blue mousse to fill up the rest of that alginate. Once that disilicone sets, I'm going to pull it out of the alginate. And now I have a flexible representation of the patient's teeth with the prepared surfaces, the fillings out, the old filling material, whatever. I'm going to trim and I'm going to use my matrix to put my composite into the matrix and seat it over the disilicone and then cure it. And then I can pop that entire thing off of the disilicone, cut it into individual teeth, and bond those onto the teeth. Let me show you. So here's my wax up, and I made a matrix. I want you to imagine that this tan piece here is the patient, and I've prepared here their teeth. So you can see old filling material is missing here, and there's a space where I wanted to build these teeth up, make them taller, because they wore them away. And when I try on my matrix over, I can see there's space available, right? So this is the patient's mouth. I take an alginate of what I did in the patient's mouth. So now I have these teeth where I removed the filling material and the teeth are short because they're worn. And I take that matrix, that alginate. I pour up the teeth with the disilicone over here. And then I put blue mousse over the top of it so I have something to grab onto. Now, chair side, I have a representation of the prepared teeth from the patient's mouth. Patient is still sitting in the chair. I'm working on the counter right behind them. And I can try on my matrix over that to make sure it fits like it did in the mouth. I then inject ProTemp Plus or even composite into this and seat it on the disilicone and let it set up or hit it with a light and let it set up. Now I can pull that off. Well, let me go back. I can pull that off. And now I have these basically like temporaries, right? I then section them with a little disc. So they're individual teeth, because a lot of these cases, I need to move individual teeth because we're doing ortho. I can't have them bonded together. I then go back in the mouth and try them on. And then I individually bond on each of these onto the teeth and then just shape them up. Now I've rebuilt the posterior teeth. So that's the Parkell method. Another thing you can do for posterior teeth is what's called the copyplast placement. So I'm using that same copyplast I had before, the duplicated wax up. I make the copyplast 1.5 millimeter. I prepare the tooth, remove tooth material and everything, whatever I need to do. A lot of times I'm not removing cavities on these. I'm just building over them when I use this method. I put heated composite into the matrix and I seat it over the teeth and cure it and shape it. So let's look at it, what it looks like. I'll go back so you can read that. Um, it's difficult to do more than one tooth at a time with this. And as you're doing this, you introduce more and more error. So in a case where this is a phased case and isn't having ortho, you're going to have a lot of occlusal adjustments with this. There's different ways to do it. If this is an ortho case, it's less important that you have a good occlusion. So again, here's this case, just like the Parkel method, but rather than take an alginate, I'm going to put composite into this, and then I'm going to seat it on that back tooth. And I need to make sure I have good positive stops with this 1.5 millimeter copyplast. And I'm going to cure it, and now I've rebuilt that back tooth. And I can trim it up, make sure it flosses well, and then I can go on to the next tooth. Now here, what I did here is I put the composite on the tooth first, and then tried to seat the matrix over the model and stamp it. And I'm going to tell you, don't do this because you just get bubbles. It never works the way you want to. It is very messy. I put it into the matrix and then seated over the teeth. It just works better. This is now my preferred method for doing posterior teeth. I will do 3D printed onlays on the back teeth. I can make them super thin and I bond them on, and I can have individual teeth. Or I will use 3M Z100 blocks and mill them. I can also make these very thin, and I can mill them and then bond them onto the little teeth. Now, why would I do 3D printing over this? Because with the blocks, I have to pay for the whole block, and it's expensive. With 3D printing, I just have to pay for whatever resin to do that. I do have to buy the machine though, so it was more expensive to have a machine. So here's a case where we need to increase the vertical dimension in the posterior. Ortho tried to close the posterior bite. They can't. This is a canine replacement, extraction, retraction, 4 bicuspid extraction, surgical case that we wouldn't do surgery. So we needed to close the posterior bite. So I went through and air-abraded all the teeth, and I bonded on 3D printed occlusal onlays. There it is on the upper. We had to take those bite stops off and bonded all those on, and I closed his posterior occlusion. So then I could start working on these front teeth. All right, so you get done and you go through ortho and the patient is all the way done. What do you do? One thing is you can just leave it the way it is. A lot of times people like my bonding. I probably need to be worse at bonding because they like the way it looks and they don't want to do crown and bridge. This is why I charge a decent amount to do my bonding so that I get paid. You have to get paid and make this work worth your while. You can't do this for free. You can't expect that you're going to get your crowns because they may not want to. I will do an aesthetic upgrade where I carve out the composite, carve out some of the tooth, and layer in and color it so the incisal edge looks better, right? That aesthetic upgrade that I showed you. I will do ceramics. Sometimes we do this and we say, this is our trial. These are our temporaries for ceramics. So at the end of it, now the teeth are where they're supposed to be. They're the right shape. We've tried everything out. They love the way it looks. All I have to do is repeat that in ceramics, right? And I can do phase replacement. If every tooth in the mouth needs to be done, I can do a quadrant at a time. And I can do all the posterior quadrant in CEREC in office and only send the anteriors out because I don't stain and glaze as well as a lab does. And I don't do cutback, and I want cutback a lot of times. Occasionally, I'll tell people, hey, we need the ceramics and everything done. And what I will do is if you commit to do the ceramics with me, then I will apply part of the fee for the transitional bonding to the ceramics to make it easier for you to do later, but you have to commit to do it with me and you have to do it at a certain time frame. So that's another thing you can do in order to get to your ceramics later. Take some of the fee, not all of it, some of the fee and apply it to the crown. Make sure you're charging for your diagnostic cast and wax up. Do not do this for free. And charge a decent amount, especially if you're doing it by yourself. Charge the lab fee, right? Because it's work. When I look at my transitional bonding in the anterior, I am charging what's called a direct veneer, because that's what this is. A direct veneer is a bulk buildup of a tooth and then aesthetic layering onto it. And when I think of my bulk veneer, I split it into two things. The bulk fill, getting the tooth the right shape, and then the aesthetics added into it later. So I have two fees. One is that transitional bonding. When I look at my direct veneer fee, whatever that fee is, I split it 70-30. 70% of that is my transitional bonding. 30% is my aesthetic upgrade, right? That's how I do it. Whatever fee you're going to have for a direct veneer, $700, $900. People charge more, people charge less. Make it worth your time, though, for the transitional bonding. For the back teeth, I make a choice. Sometimes I call it a buildup. Sometimes I call it an MODBL. Sometimes I call it a composite onlay, or sometimes I call it transitional bonding. I look at what needs to be done, how much it's going to cost, and I look at what their reimbursement is and what the fees are. And I pick one of those, right? There's no right or wrong way to do this transitional bonding. I also, if there's a crown, I generally want to replace that crown. At the beginning of treatment, going into ortho, I want to know what's under those old crowns. So if it's an old PFM, I'm cutting it off, I'm cleaning it up, and I'm placing a long-term provisional crown, and there's a fee for that. It has to be like 6 months or something, and I'm bonding it onto the tooth so that later when I go to do the final ceramic on that and replace it, I'm just prepping a crown. I just prep it. And whatever I put on there is my buildup now. It becomes my buildup. And I just make sure I have clean margins around the side. So let's look at a couple cases. This is a canine replacement vertical maxillary excess case. When we look at this, she has very, very long teeth, and they're the wrong shape. The canines were not made into laterals well. This is a multidisciplinary case. She also has, she had ortho before where they extracted things. It's just a tough case. So I have big, bulky teeth that are in the wrong position, and I have lower teeth that are too narrow and are short and with wear. So, and this is a surgical case that wouldn't do surgery. So we need to stabilize her while she goes through ortho so that then we can later on make things look better. So for the lowers, I did injection molding, right? And we waxed them up and we put them in the wrong position because that's where they were, but we gave her whole teeth. For the uppers, I cut the crowns off and we made sure we had appropriately shaped 3D printed crowns and bonded them on. And we can now reshape these as time goes on too. We made them the proper width and the proper height. She's going to have some gum surgery to cover some of this stuff up, and we're doing ortho. And here she is part way through her ortho. We need to place TADs on her to get things where they want to be, but she turned down the TADs. So we're talking her into doing the TADs now. So she's looking worse before she gets better. And honestly, she's a surgical case for this gummy smile. It's never going to be as pretty as I want it to be. It's never going to be as pretty as I want it to be unless we do surgery or we get TADs in there. This is 3D milled upper and injection molding on the lower. So here's a case where on the upper, the entire lingual of these teeth is gone from erosion and the lower teeth are worn away. So we injection molded the lowers, keeping the orientation of the roots, and we 3D printed pieces to go over the upper teeth. I think I 3D milled these out of Z100 and bonded those on. So you can see the entire lingual's gone on those uppers, and those lowers were sitting there. And we bonded everything back on there, did some injection molding on the lower. Now, as he went through treatment, because we put him only in anterior occlusion, guess what happened? He chipped them. All right. It's okay. I just fixed it. I just fixed it with some composite. It's fine. It's temporary. At the end of treatment, we're crowning and bridging this guy. And I just finished this case recently. I just don't have the photos put up yet. Anterior transitional bonding. This is the case you saw before, where he has compensatory eruption and wear in the upper and lower segment. So we bonded everything back the way it should be, gave him a stepped occlusion, did ortho, put everything the way it's supposed to be, and now we're going to do, I think, 4 veneers upper, 4 veneers lower. Here's another one where we have wear, teeth that are not the right shape, diastema, and we bonded onto these, and now he's in ortho, getting everything straightened out. And at the very end, we're probably just going to do an aesthetic upgrade on him because this was a financial concern. So I hope that explains transitional bonding or transitional reconstruction. If you have any questions about this, let me know. But this is treatment you can do, but it does take a little thinking and it takes working with your specialist. And like I said, always begin with the end in mind. Have a great plan, and you can do these cases. If you have any questions, let me know. Hope you enjoyed this.